All right, I want to welcome you all to what I hope you'll find is a special episode of this podcast. Today on the Herle Burly, we're going to talk about the state of healthcare and healthcare funding in this country, and we have three former premiers here to help us do it. Moving from east to west, Stephen McNeil, the 28th Premier of Nova Scotia, Kathleen Wynne, the 25th Premier of Ontario, and Christy Clark, the 35th Premier of British Columbia. There's a lot of noise out there on this topic right now. I'd like to wade through that with the people who know the system intimately, who know what it's like to administer it, the opportunities and challenges therein. Can greater efficiencies be found without compromising service? How much more money does the system require, and what level of government should that come from? What are the impediments leaders face and we face to reform of the system? In other words, let's get past the sturm and drang and talk about realities with people who've lived this challenge. Premiers Clark, Wynne, and O'Neill, welcome to the Herle Burly. It's a real honor for me to have you all on here today, and I'm especially excited about this topic. Thank you all for coming.
It's great to be back, David.
Yeah, thanks for having us, David.
Good to be with you, David.
Good to be with you.
We've been waiting for someone to call us to ask us our opinion.
Hey, it's the beginning of August. How have you all been spending your summers?
Playing golf, working.
Playing golf?
I've been, since the sun came out in Vancouver, which was like a week ago, I've been in the Gulf Islands.
Oh,
hanging out on the beach.
Nice.
I've been with grandkids and kids, and we're going on a canoe trip in a couple of weeks. So getting outside as much as I can with my kids. First year in more than 20 years that I'm not in the legislature. So it was kind of weird watching the legislature start this week. But I'm getting over it.
It was weird for everybody, Kathleen. So thanks for clearing your schedules for this conversation. I do think it's really important. The news is full of bad stories about healthcare right now. Emergency room closures, shortages of doctors and nurses, long delays for elective procedures. It all seems to have been greatly exacerbated by COVID. However, many of these things were issues before COVID, and the cost of healthcare has been an issue for as long as I've been following politics. Many Canadians were shocked at how fragile the system was during COVID. In the background of all of this is the ongoing provincial demand, so far unanswered from Ottawa, for more federal money for healthcare. The three of you have seen this from the inside, had to run and pay for a province's healthcare system. I'm hoping that we can have an honest conversation about what kind of reforms, if any, are necessary to the system, whether we can make it better, and what are the roadblocks to that. Do we need to make it more efficient? And if so, how would we do that? Are there possibilities for expansion, dental, drugs, long-term care? And how much more money does it need, and where should that money come from? So maybe I could start with just asking you, when you took over your jobs as Premier, when you became Premier of the province, what kind of a briefing did you get on the state of your province's healthcare system? Kathleen, maybe you could start us off.
Sure. When I took over in 2013, obviously I had been sitting in cabinet for a number of years before that, David. So I was aware of the challenges. We were at that point trying to work towards a balanced budget, and our healthcare costs were the increases in healthcare were the biggest challenge that we had to face. I will be honest. One of the things that I was intent on doing was finding ways to make rational decisions around healthcare, but find ways to slow down the increase in costs. That was my objective at that point, particularly in drug costs. I think it was like over 6% increase annually, and it just was not sustainable. So I was not at all interested and did not want to cut the budgets. But we were still trying to climb out. I mean, it sounds kind of ridiculous now with the deficits that governments are running, but we were trying to climb out of the deficit that had been incurred because of 2008, 2009, and that was the challenge we were confronting.
Stephen, how about you?
Obviously, our financial situation in 2013 probably was similar to what Kathleen is describing. Obviously, a smaller budget, but we were $500 million in the hole annually. We were looking the healthcare costs were continuing to escalate. We were trying to figure out how could we get ourselves into a fiscal position where we could invest in infrastructure We, as a government, invested the largest infrastructure investment in the province. Our central hospital in Halifax was in decay, quite frankly. It should have been replaced a decade before. So we were going through all of that, not to mention, we were starting to see the HR problem show up in 2013-14. The issues of doctors retiring with very large practices. We were seeing newer physicians coming in, not wanting to actually run in a or operate in a fee-for-service kind of clinic. They wanted to be more in a collaborative center, which was a new idea really for here. There was some that had happened in some parts of the province, but we were starting to move and take the system in a different direction. Really was moving towards a collaborative model of healthcare, because we knew we weren't going to be able to have enough doctors. We needed to introduce the idea of nurse practitioners, and it sounds silly today to talk about introducing the idea, but in 2003, when I was first elected, if I talked about nurse practitioners, doctors would have been opposed to it because they would have felt like they were taking their easy patients. And the flip of that is, I was leaving office, doctors who were getting ready to retire wanted a nurse practitioner. We were seeing the determinants of health. It was my view that we should have social workers in some of our clinics to deal with the underlying of health that aren't related. They end up being medical issues, but how do we support those families? So we were on the front end of this. We saw this in some ways coming. I don't think it's unique to, I think all of us probably saw the HR issues that were happening, people wanting to practice differently. So we were trying to figure out how do we best do that inside of the fiscal envelope that we had to deliver those services. And as you know, when you start talking money, it's interesting. And the other thing that I would say to you that I think one of the challenges in healthcare, the entire envelope of healthcare is run by professionals and professional organizations. One of my frustrations always was that they never respected each other's scope of practice. If we had suggested that paramedics should do a certain job, I'd hear from the nurses union. If, there's no way, in my view, that a doctor should be running a clinic to give flu shots. We have other work for them to do. But once you start in that, pharmacists, once you start wanting to broaden someone's scope, someone else then starts feeling like you're stepping on their toes. And that's one of the challenges of reshaping healthcare.
Excellent intro. Thanks. Christy, what did you inherit?
Well, like everybody else, I inherited a big, fat, ugly deficit that we had to eliminate. So over $1 billion, I think. And we did, we ran 5 balanced budgets after that, but it was really hard to get there. And I remember I'd been in cabinet too, but I'd taken a stint in private sector in radio, as you know, between then. And I remember there were 2 facts that stick out at you. One is 50 cents of every tax dollar that you get from the people of your province goes to pay for healthcare. That's it. So everything, the other half dollar that you get goes to everything else, including education, including universities, including child protection, environmental protection, you name it, right? Everything else. So first of all, it eats up this massive part of your ability to be able to look after other things. And it's constantly growing. The other thing was that the federal government had backed so far out of supporting healthcare. I never really, most Canadians, and I was one of them, had always thought, well, the feds pay for half of healthcare. They don't. They pay for somewhere, depending on the province, depending on the year, 19 to about 23% of healthcare. They're the worst partner in the world. That's seriously, that's like you're renting an apartment with somebody and you're paying 3/4 of the rent, but they're in the shower all morning, using up all the hot water and the utilities, right? So, it makes it hard when you've got such a lousy partner. And that's, irrespective of political conservatives, liberals, all have that problem. And of course, drug costs are a massive part of the budget, and technology costs, staffing costs. And Stephen talked a little bit about the unions. It's not just for me, I would say the scope of practice is a huge problem. But we also, when I became the premier, we had a lot of private care in British Columbia that was working alongside the public system in a very small way, but hopefully with an ambition to be like all of the European countries the Swedes and the French and the English and the Germans and the Finns and everybody else. But we had more private care than any other province than Quebec. And we were working to try and to allow that to expand. The unions, though, were fighting to try and shut it all down. And that's, so when I'll just finish with this, David, because I remember the whole time I was in government, starting in 2001, the unions, the nurses, the doctors, the paramedics, everybody was saying, Christy, this system is hanging by a thread. Like, we are just holding it together with Scotch tape in the emergency rooms and in the hospitals. Well, now after COVID, guess what happened? COVID has finally broken the system. And I think all of that kind of hard work that everybody was just doing overtime to hold things together just another day, it's not possible anymore. And so I think we are really on the edge of some very dramatic change in our healthcare system, or we're going to lose it.
So
David, can I just jump in on, because some of the things that Stephen and Christy have said. I mean, when I came in, we were also in the process of reform. The wait time reductions, like there was a lot of work that Dalton had done, putting money into reducing wait times in some specific areas. We were trying to create that collaborative model that Stephen was talking about. And we also were trying to coordinate care. We were trying to create a regional model with our local health integration networks and try to bring some rational kind of allocation of dollars on a regional basis and coordination of the need across the province. So it's not as though in any of our provinces there wasn't an attempt at reform, and I think that's important for us to recognize that, it wasn't static. We weren't just saying, well, we just want to keep everything the way it is and we just want more money from the feds. We were all working hard. And I remember sitting with these guys at the Council of the Federation table. We were all trying to find ways to do this better, to provide support. And I think that, yes, the system is in real trouble right now and we'll get into that. But, and part of it is the money, part of it is what Christy's talking about in terms of the percentage paid by the feds. But I think there are some sort of larger existential issues around healthcare that we haven't grappled with as Canadians. And I think we have to be honest about having those conversations, and I mean, that's part of what we want to talk about today.
What would be one of them?
Well, I think there's a question, for example, about as new technology is available, is it all just additive? Do we just provide every test for every person without any constraints on the practitioners? I had a conversation with a doc earlier this week about the practice guidelines around MRIs, CTs, and X-rays, for example. And there are guidelines in place about when you do which one. But if you can walk down the street to a walk-in clinic and get the MRI that your doctor has said is not necessary, then that's a cost to the healthcare system. So how do we manage the expectations of people who know about technology and I mean, think I don't want to sound arrogant, but I think that all of us as patients, we think we know what's best for ourselves and for our kids. I grew up in a doc's family, a family doc's household, and my dad was listened to by his patients. People believed him, took what he said for gospel, which I will say was not always a good thing. They needed to push back on old JB, but that has completely been flipped on its head now. And I think it's very difficult for doctors to adhere to, a set of guidelines when you've got patients coming in and saying, I want all these tests every time, right?
All right, Herle Burly-ites, I've got to come clean. I'm no economics guru, although I've been lucky to work with a few of them. But in my life as a researcher, I know powerful numbers when I see them. So today, we're going to dive into the economic story of spectrum policy in Canada. I tell it to you on behalf of our presenting sponsor, TELUS. It's a big story, or rather, it could be a big story, because at the moment, it's all about the economics of missed opportunity. Let me explain, and maybe you want to get out your pencils. According to StatsCan, our wireless industry already contributes $47 billion a year to the Canadian economy. Big number, right? But it won't shock our smart listeners to know that the potential contribution of 5G could be immense. According to an estimate from PwC, $94 billion in additional GDP per year. But it all relies on government policy, and right now, it's money that's being left on the table. Specifically, one estimate by GSMA shows that $30 billion in additional GDP is currently being unrealized because our spectrum policy isn't keeping pace with international best practices. We're way behind in our spectrum auctioning, the 38th country in the world to begin auctioning critical mid-band spectrum for 5G. And at the current rate of progress, until between 2025 and 2027, there will be less spectrum for 5G available here than in 21 out of 24 benchmark countries. Beyond the numbers, it's not like this stuff won't have any impact on how we live our lives. There are massive shifts this technology brings. Automation into manufacturing, supply chain efficiencies, God knows we feel that one, healthcare innovation, and agricultural practices moving from analog to digital. How food is grown and gets to your table more efficiently, which has measurable impact on climate change. I've thrown a lot at you, Herle Burly-ites, but here's the short story. We need all the spectrum. The sooner, the better. I just want to be clear. So what I find so interesting about this is that all three of you are saying that the challenge you fundamentally faced was financial. Like when you came in, people didn't say to you, the bureaucrats didn't say, well, here's what you need to do to get knee replacements done more quickly in this province. They said, here's what you got to do to get costs down.
So I don't know.
No, they also said,
yeah.
Sorry, they also said, here's what you need to do to get knee replacement wait times down. Sorry, Steve.
But I would also say, Dave, wasn't the only issue. There was a structural problem in healthcare, and I'll only speak to Nova Scotia. We're operating on a model of 1950. We had 3 emergency rooms 30 minutes apart from one another in a part of the province. We closed 2 of them to rebuild the infrastructure in those communities to meet the needs of today and the next 50 years. Well, I almost got burnt at the stake because it's such a personal thing, and it's hard for governments to be able to reshape the delivery model. I spoke at the beginning of this about the Victoria General Hospital that we have to replace because it was in a position of really there was no other option. You couldn't drink the water in it. There was leaks in the building all the time. It should have been replaced decades before. It was an opportunity to reshape the delivery model, and we were able to do that, and it's happening now. But in many parts of our province, and I would argue in many parts of our country, changing the delivery model is as important as trying to control the costs of how you're delivering that service. Kathleen talked about new technology. As I'm sitting here in Halifax, there's a robot probably doing an operation in downtown Halifax. We now know, that when I was a kid, every family doc did the surgeries in the local hospital. That's not the case anymore. We have specialists. Well, we need to improve the infrastructure. That doesn't mean we have to get rid of buildings, but we have to make what goes on inside of those buildings meet the realities of today and of the patient. But when you start that and it gets caught up in the political conversation, let's not lose sight of the fact that this part of the challenges in changing healthcare is it's in the political realm. Sometimes when you have to make decisions as a premier or as a government, there's usually someone who doesn't like that decision because there are people vested in the status quo in healthcare because it's working for them, but it's not necessarily working for the patient.
And it's not, I totally agree with Stephen because we did a fair amount of that work too. I do think there are areas where you can make good, really smart investments that pay off. And so I think BC is a good example. That it's not me, it's my predecessor, made tons of investment in seniors' homes across the province. And so when COVID hit, no one was preparing for COVID. We all know that in retrospect now, but we didn't have the number of deaths in seniors' homes that people did in other provinces because we had very modern, lots of single room seniors' homes. And there's no doubt lots of people, senior citizens died terrible deaths, lonely deaths during COVID. But those kinds of investments in infrastructure really make a difference. I do think, though, We are going to have to, like, population is aging. It's getting way more expensive to look after people. If we want to be able to look after younger people as well as older people in the future, I mean, the answer to Kathleen's question, I think, is, obvious, but a sacred cow. If people want to get services in the system that their doctor won't recommend or hasn't recommended, they should be allowed to pay for it. You should be allowed to go for your MRI. You should be allowed to go for your knee replacement. You should be allowed to go for those services at the moment that aren't surgically necessary. But the federal government Harper's government actually wasn't so bad on this. They would pretend to make a noise, but they wouldn't do it. Justin's government is predictably the exact opposite on that front. If we cannot provide the new technologies and the new drugs that are available to people in every other country in the world, in the Western world, I don't think we have a third world healthcare system now. I know people on the right say that all the time. We will, if we can't keep up in providing those expensive new drugs and expensive new technologies that are really necessary for keeping people healthy. We'll be the only country in the world that doesn't do it.
But two things about that. Christy, I would argue that, and so I'm talking from the Ontario perspective, but I would argue that we do provide those services to people. We have world-class technology. We have world-class surgeons and practitioners in Ontario. But I think that what I'm talking about is the services that go beyond what a doctor, what the evidence recommends, right?
Yeah.
Those are the services I'm talking about. And your solution, this is my second point, your solution about people should have the right to pay for it, that would be a non-starter in Ontario. I mean, that will cause a huge conflict in Ontario. I would suggest it would cause a conflict and will cause a conflict across the country. I think the discussion is coming. I mean, Doug Ford indicated in his throne speech that they're going to be innovative solutions. And I read that he's going to try to push the envelope on privatization. That will cause a huge problem in Ontario. And I think it distracts us from the reality that there are ways of doing the things that we need to do. It is going to take some more investment from the federal government. Infrastructure is necessary, but we've got to grapple with these other issues of the culture around medicine at the same time.
Yes, I agree with you. We do have to do both at the same time. But I mean, I do understand it's really politically really hard. But I'm not in politics anymore. So I'm just talking about the stuff that we should be doing in Canada. And that actually, I think that we're going to be, I don't think it's avoidable any longer. I just don't think this debate, I don't think our healthcare system we can continue to support it in the way that we have with this 100% lockdown public system that no one else has in the world, in the Western world, and that is the second most expensive per capita anywhere in the Western world except for the United States.
Stephen, where are you at on the Canada Health Act?
We're all saying the status quo is not working. So to say that we're going to try to fix it in the status quo is not a mature conversation that our country should be having. Whether or not, listen, I go to my doctor, I see my doctor. The province, he's an entrepreneur. He runs his own office. He's a private businessman. There are many in this province and I just don't pay him. The government pays him. So why not look at the situation where we do the same thing about MRIs? The doctor has to authorize, we get it. We negotiate a deal with someone who's operating an MRI machine, and I go and say I need my MRI. I don't know whether we should ever get there or not, but we have to have the conversation about it. The problem with it is everybody says we don't want to be the U.S. Well, I agree with them. I don't want to be the U.S. either, but there's lots of other countries. There's lots of other different ways of delivering healthcare around the world that we should look at and say, not to throw out our system, but this is not my grandfather's province anymore. What does that look like? We have to change how we're delivering healthcare. Otherwise, it is simply not sustainable.
Stephen, why would private delivery, just demystify this for me? Why would private delivery of a service, which has to build in a profit margin, be cheaper than public delivery of that same service?
So let's move away from thinking about it being cheaper. Maybe I can create a system that is more receptive to the patient.
without cost. This isn't going to be cheap. Healthcare has never gone down, to my knowledge. The cost of delivering healthcare has not gone down in any year that I was elected, and I don't think it's gone down any year before that or any year after. So the question is, how do you create a modern system that meets the needs of the patient around the people who are delivering? And it may be that we don't do a private system. It may be, but surely to God, as Canadians, we could have that conversation. And Kathleen may be absolutely right. Canadians will resoundingly say that's not going to work. But when we do it in the vacuum of saying a private healthcare is the only model to be used as the U.S. model, well, that's not true. So,
Stephen, are you talking about private delivery, public payment, or are you talking about private pay? Because there's different. I mean, we have private delivery of some services in all of our provinces, right? That are publicly paid.
Right. So you could do that, but so we could look at that particular. We could do it that way, or I don't think we should move. I don't think we should be to not want to have the conversation about what does the other model look like. I'm not saying we should do it, but to automatically say no when we know our system's not working. Like we all know this. The pandemic, pre-pandemic, the system wasn't working. Let's be honest.
And it's not about having an American system either. It's about having a European style system or something like that, where you can have all three things, right? You can have public paid, public delivered, private delivered, public paid, and private paid, private delivered. And what it does, in answer to your question, David, is it takes a lot of people out of the lineup for MRIs and knee surgeries so that not everybody has to wait 6-12 months to be able to get back to work. And those people pay taxes into the public system, but they don't take out of the public system. They pay privately for that. So it may be way more expensive for them, but it makes it a lot more manageable for those of us who want to use public care.
Well, and we also know that if someone's injured, for example, and if they're not back to work in 24 months, the odds are they're not going back to work. And some of that is waiting for to have the back surgery required to get them back to work. But in the process of waiting so long, all kinds of other health issues begin to show up. So whatever the combination looks like, the country has to have a conversation about it. And I don't think we should exclude anything. I think we should put it on the table to say, what does this look like for Canada? Without, we all agree we don't want the U.S. system, but what does our modern healthcare system look like? Understanding, healthcare providers want to practice differently. Even that in itself has changed drastically on the delivery of healthcare. There's, Kathleen, your dad probably, your father probably had 5,000 patients, or probably had the entire town. Yeah. Where the person replacing him today, God, if 1,500 would be a stretch.
But doctors don't want to give up on fee for service, do they?
Oh, some do.
Some do.
Some do, yeah.
Some do. Some want to be salaried, David, and some want to work in that collaborative environment that Stephen was talking about. A lot of the young ones absolutely do want that. But I just think we need to step back before we leap to we've got to look at privatized models. We've got to push on that. I think that there are barriers within what we're doing now that make the system not work for people. So the big one that I was always pushing, and I had a really hard time with this because of my upbringing and because I watched my dad go through the beginnings of Medicare and watched what his practice looked like. The availability of 24/7 care for people is a huge issue. And, we've moved away from a culture of expectation that the primary caregiver is going to provide that 24/7 availability. And that I think that has naturally created pressure on our emergency system, because I don't care how many telehealth lines you set up. If your new baby is having a problem and you don't know anything about a baby, you're going to the emerge, And so, but if your doc is available to you, who knows you and who can help you, then you're going to trust that person. So I think that within the system, we've got work to do. And, things like conflict, Stephen, you talked about scope of practice, but even within the physician community, there's lots of conflict between family docs and specialists, and the remuneration issues are huge. And we've got to resolve those, because why is a family doctor remunerated at so much lower level than specialists when we actually need primary care physicians and nurse practitioners to do more. We need them to actually be the fabric of to weave together the system, and yet we don't pay them for it and we don't expect it of them. So see, I want to see that stuff fixed before we push on let's just have private care, because Christy, I really think, and Stephen, don't you think that leads to people who are already marginalized being more marginalized?
It very well could, but all I'm saying, Kathleen, is we have to have the conversation. The system is not working, so I think if we start from that point, and I can give you 100,000 Nova Scotians that'll tell you today the system's not working for them because they don't have a doctor. So And trust me, I was on it when there were 60,000. We're working to try to solve those problems. So
and that really matters to people. Just to interject for a second, Stephen. I mean, I've seen research that indicates there's nothing more important to people than to have a family. Like if they don't have a family doctor, they don't think they can access the system. Like they just don't think they have the right gatekeeper. That's the gatekeeper.
But we have to have that has to change. Our mindset has to move toward the fact that when I need primary care, I have a place to go. Who delivers that primary care may be different. I have I was, when you sent me that, I was with a couple of my brothers and we were talking about.
A couple, like you've got 9 brothers, don't you? 13?
we were in the middle of
you had like a whole baseball team of brothers, didn't you?
A soccer team.
We were playing golf. We probably should play baseball by the look at our golf game. But one of them was saying, he prefers the nurse practitioner over the physician. Now he falls under a physician, but he often sees the nurse practitioner. There are family practice nurses who need to be part of that. Kathleen was talking about if you have a newborn. If my mother was busy when we had a newborn, we would call the local hospital and actually talk to the nurse that was on call. That nurse would say, "Come in or not," and they would reassure you, and they would be able to tell you whether you should come or not come. But this idea that we have locked in our head that it has to be a doctor. Yes, we can fall under a doctor, or we can fall into a practice that has, but what are the other parts of this? I believe dietitians should be part of this conversation. Mm-hmm. We have chronic issue around diabetes. We have chronic issue across this country around diabetes. We need social workers as part of some of our communities on how do we deal with the healthcare issues that some families are facing. That doesn't require a doctor. That requires someone else who can come in and work with that. But we have to be willing to say that the current model has to change. Mm-hmm. The other thing, which drives me crazy, to go this one little thing that Kathleen was talking about. I have no one. I could never understand this, and I fought and I argued and I tried to get it to do an Atlantic model of, instead of a College of Physicians in Atlantic Canada, have one college. Because I think there should be one in Canada. If you're a medically trained doctor in Canada, why do I have to register it to be part of the Nova Scotia College of Physicians? Why? It makes absolutely no sense. And if I want to get a doctor from Ontario to come here to go to Yarmouth for a weekend to cover shifts, and we'll supply them with 2 extra days at the White Point for their family to come with them, there's a whole bunch of rigmarole they have to go to prove that they're competent to operate in Canada. Well, they have a medical doctor's license. Why do we have all of these colleges? Because physicians, it was a way to actually control supply.
Yeah.
Well, hallelujah, Jesus. I agree with that. Interprovincial trade, interprovincial freedom for professionals to move across the country, whether you're a trucker or a doctor or a bricklayer or a nurse or a teacher.
The irony of it is, Christy, the electrician can. The doctor can't. That's what's bizarre.
Exactly.
Without going through these rigmaroles. And it makes, so to me, it's an acknowledgement by provinces. And I used to argue this with it's an acknowledgement of failure by our provinces that we can't retain you other than by regulating you into staying here. Well, that's not a way for a system to be vibrant. And I think it actually provides an opportunity for whether it's locum services or how we do that. But to me, it's symbolic of the system that it is so bureaucratic, and it's not just government. I think, and that's where I think this is why I think a national conversation about healthcare, about everybody has to be at the table. Listen, I used to get a prescription from a doctor. I would take it to my pharmacist to talk to me about what the interaction I might have with this thing, not the doctor. For God's sakes, why do I have to go back to see my doctor to get a prescription renewed? The pharmacist is trained to deal with the drug interactions and drug medication. Yes, I might go see my doctor once, but we're churning people through doctor's office for stuff that, in my view, the system and a mature conversation could deal with outside of the doctor's office.
So think about global supply chains as rivers of chaos requiring deft navigation. Producers and shippers nowadays must work around constantly evolving choke points and blockages, which are in turn created by events like COVID, which is still a thing, and foreign factory lockdowns, and wars, and extreme weather. This is a time of disruption. And the invasion of Ukraine magnified it, cutting off one of the world's great agricultural centers. Africa, in particular, is pleading for grain. Our sponsor, CN, is at the bedrock of our supply chain, especially where shipping Canadian grain is concerned. The railway is seeing surging demand for a range of commodities. Its analysts are predicting intense pressure on Canada's entire transportation system in the coming year, and grain will be part of that. After last year's drought, our farmers are expecting a return to normal crop volumes. As I've said here before, CN has spent a great deal of money to ensure its trains and tracks and railroaders will be able to transport this year's grain crop efficiently. As it does every year, CN has produced a detailed grain plan, anticipating crop yields and cargo flows. The idea is to operate at maximum capacity, and key to accomplishing that is something railroaders call corridor balance, ensuring that cargo bound for overseas customers is more or less evenly spread among Canada's ports, east and west, rather than concentrated on one coast, which seems to be a trend. Here's an example. During the 2020-2021 crop year, grain shippers sent about 4 million tons of Canadian grain to Europe and Africa, but used ports in BC rather than East Coast ports. CN's goal is pretty simple, to ship cargo safely and on time. Absent extreme weather events beyond anyone's control, the sort of thing we saw last year, the railway has the capacity to do it. But ports in Thunder Bay, Montreal, and Quebec City are ready and able to handle heavier cargo loads. Put simply, this is a year in which Canada's supply chains would benefit greatly if shipments tipped eastward again. So, how do you decide that something in healthcare is costing too much money, or that healthcare is costing too much money? If I was to ask the citizens of your provinces what the most important thing government does for them is, they would say the healthcare system. And so for years, I've been hearing people say, well, it eats up the budgets and it takes up too much money. Well, what's wrong with that?
Because we have kids that we want to be able to go to school. And we have universities that we want to be able to innovate and invent and come up with new thoughts and new thinking, because we have environment that we want to protect, and we want to, that is ultimately the problem, right? So you've got, I would argue a couple of problems in Canada. One is there is just, the feds have backed out of healthcare funding it. So it's all on the province's shoulders now, or 75% of it is. And the provinces just can't afford this within our own budgets, given all of the other services that we need to provide. And so, it really is like cutting up a pie. You've got, when your budget goes from, we were at about $25 billion when I left to, say, $29 billion. And as a percentage of the pie is continuing to grow, everything else is shrinking. That's the problem that you've got, because you can only raise taxes so much, and all your revenue.
I was going to say, can't you raise revenue?
Well, sure you can, but we all know that when your taxes get to a certain level, it does get harder and harder to raise revenue, and that's been proven all over the country, right? So, first, that's the first problem. We don't have enough money in the country and in the system. The second problem is the system is very rigid, so there's very little tolerance for any kind of any kind of letting off of the steam into any sort of private care, like they have in a parallel private system, like they have in Sweden and Finland and Denmark and everywhere else in the Western world except the United States. And the third thing is is that the federal government, the federal government tries to control healthcare. They don't know a thing about healthcare. And I remember during the COVID debate, lots of these guys were arguing, if only the federal government could decide what was going to happen with COVID. Like, they don't even employ anybody who gives who gives a shot, puts a shot in people's arms. Like, they don't even know any of that stuff. So they need, what they really need to do is loosen up on healthcare and let provinces innovate. We have this incredible breeding ground of new ideas across the country where you've got 10 provinces, each of whom has its own healthcare system and deep experience at running it, and each has its own culture to some extent.
What part of the healthcare system?
Let the provinces innovate around that.
What part of the Canada Health Act would you want them to loosen?
It was Monique Bégin who added the anti-private healthcare provisions in the system. That would be the first one I think that they need to look after.
Public administration, you're saying the public administration part.
Yeah. And the second thing that they do that's a real problem is that they come up with all these funding formulas for the pennies that they throw to the provinces. That less than a quarter that they send to the provinces. They say, okay, look, you can only have this money if you spend it on X, Y, and Z, which is politically popular to them. But what it means is the whole system gets scramulated, and all that money that was going to something else in the system, because it's a fixed budget, ends up going to the federal priorities. And, the feds can't pretend that they know how to run healthcare. They don't, and they shouldn't try.
But I also think, in Christy, in fairness to the feds, and this I was there under two prime ministers, both Harper and the current Prime Minister Trudeau. I wouldn't be sending a blank check to provinces either. Let's quite frankly, provinces, you can go back and look, Paul Martin gave $5.5 billion to wait times. Well, wait times didn't come down. Where'd the money go? I think there has to be some accountability on provinces. Collective agreements, I guarantee you, were signed beyond the ability of the provinces to pay you federal money. I was sitting there with them. We don't give money in the province. I didn't anyway. I didn't say to the health authority, here's your money. Go do what you want with it. We said, what are you doing? Where are the deliverables? These are the things that are priorities of ours. I think that's should the federal government have ante up more money for this conversation? Absolutely, 100%. But we say 50. The provinces say 50. I shouldn't say we because I'm no longer we. The provinces say 50. The federal government says it's always 30. I don't care. In this province, it was 22 cents on the dollar. You just tell me where you want me to spend it, and it's actually quite easier for me to say if they tell me they want on adolescent mental health. I can't argue that because
I understand that because I know when the feds gave more money to the provinces, what Alberta did because they had so much dough is they went out and they just gave tons of money to the unions, right? They had the highest paid nurses and doctors by a long shot in the country. And so Paul Martin comes in, he goes, no, wait a minute here. I want you to spend it on this. But as you say, he came in, the system tried to respond to that stuff with, I guess, varying degrees of success across the country. And it still didn't happen. Because they can't do it. They can't direct what provinces do. And I don't think they should.
No, and I agree, Christy. But I think we have to be careful with sweeping statements, Stephen. I mean, in fact, wait times did come down in Ontario, in very specific areas. After the Romano Commission, the wait times did go down in the areas that we'd identified. It was measurable, and we accounted for it, and we made it very clear to people, and people felt it. People felt that they had more access. So I think that having those kinds of targets, and the problem is it was in a very narrow range of services, right? And so to your point about the national discussion, I think, David, that, we have not had a conversation in this country about the Canada Health Act or, the expectations of our healthcare system for a very long time. And I think that as technology has changed, as the demographic has aged, we need to recognize that there are things that the system does well, depending on where you are, and there are things that it does very badly. I think to say that the system is broken across the board, I just don't think that's true. I think if you look at other parts of the world, we're in a much better position than some places. Obviously, we're much worse off than others. And that brings me to my second point. I lived in the Netherlands for 3 years. I had 2 babies in the Netherlands. And I can tell you, to Stephen's point about the other determinants of good health. There are a whole lot of things that go on in those countries that have a lot more to do with, providing adequate housing, providing a social safety net, that are not direct healthcare services, but have a huge impact on health. Even the fact that the transportation infrastructure is different there than it is here, that has an impact on people's health. So comparing the sort of apples to oranges is tough, Christy, when you say that, all those other countries, we have not stepped up to do some of the other things that those countries have done to support their populations, right? And so we have to recognize that. But I do think, David, we need that national conversation. We need to, what is it we want our healthcare system to do? We want it to support us in staying well. We want preventative care. We want timely care and emergency care when we're ill. I would say that's one area, emergency care, that we have done very well in. And now when that's starting to break down, people are saying, whoa, wait a minute, because it actually has done well in that area. So we need to itemize the things that we want the healthcare system to do, and then measure against those services how well we're doing.
What would start that conversation? What questions would you ask Canadians?
I think the conversation needs to, you need to, and it can't just be the politicians, quite frankly. You need to engage Canadians. We need to engage the people in the system in a way of what does what does the system look like for the next 50 years? How do we take the HR talent we have in this country and allow people to practice to their full scope? What's happening in other parts of the world? I think one of the things that we're missing here too, let's face it, Canada's got a small population spread out across. It's a lot easier to service 35 million people in New York than it is to service 35 million people across the landscape of Canada, delivering a publicly funded system. So I think we need to be mindful of that. But what do Canadians want their system to look like? They may come out to Kathleen's point. They might come to us and say we want the status quo. Just keep spending more money. Well, eventually we're going to say that's not going to work. So what do we do from there?
But I think you'd have to present people with some trade-offs and some options, David. I think, it would have to be an exercise where people would be educated about how the system works, and then they would have the opportunity for input. I have a discussion with people all the time about community hospitals in small towns. And, a community hospital is very, very important to people. But what I will say to them is, do you want to have your daughter's baby delivered by somebody who delivers 10 babies a year? Or do you want them to have a doc who's delivering, or a midwife or whoever it is, who's delivering a dozen babies a week? What is it that you want? And I think those kinds of conversations we've been really reluctant to have. We've been afraid to have them because it sounds like, when it comes from government, it sounds like we're looking to cut things. But we've got to find a way to be honest with each other. And I think in the post-COVID world, this is actually the perfect time to do it.
We'll be back in a minute after a message from our sponsor, Google.
Did the Jace dig the inning?
Google products are designed to help you find relevant local news. Learn how Google supports news in Canada at g.co/news in Canada.
What summer festivals are on now?
Google helps you find the news that matters most to you. Whether you're looking for news from international publications or your local paper, learn how Google supports news in Canada at g.co/news in Canada.
Well, I'm older than all of you. And I remember that, to your point, Kathleen, that in the 1990s, Canadians came to understand that people that were using the term reform of healthcare meant cuts. That's what it meant, right? And I think people are very leery about that term going forward because that's what it meant in the 90s.
Mm-hmm. But people the thing is, you ask people what they want from the healthcare system, and Gordon Campbell actually did this. He had this big conversation on healthcare that we did in 2002 or something, and it was huge. And everybody was allowed to come and talk about whatever they wanted. And what happened was, over the course of it was probably a year, the whole thing went on, was everybody who was engaged in the system, many of them people who were working in the system, doctors, nurses, unions, professional groups, but also people who were intellectually engaged in it, right? Who were interested in it, citizens. They came forward with all these ideas over the course of a year. The government put it together and had all of these solutions. And then they put it out there and they tried to do some of it, and everybody lost their minds. So you can have my experience of that was you can have the conversation, and it can be thoughtful, and it can be well managed, and the inputs can be excellent. But actually implementing those outputs is close to impossible. And Gordon Campbell got to do very, very, very little accomplish very little of what was in that report, because it is so hard to do this stuff. So yes, the national conversation is really important. I think, though, it isn't going to be forced by, you're not going to have a national conversation that gets us anywhere, probably very, to any point that politicians can actually implement the things through a conversation. This is actually happening, I think, right now in real time, as the system that has been fraying for decades is finally starting to come apart as a result of staff shortages, the tremendous expansion in costs in the system, and a shortage of money that governments will have to pay during the recession. So I think this conversation is going to be less of a conversation and more of a, oh geez, sorry guys, we have to do it.
Christy, don't you think the conversation though that Gordon Campbell would have had in your province, wouldn't you think that would look differently and serve the country better if we had a national conversation about, because how we deliver healthcare in each of our provinces is obviously different. It's supposed to be the same, but let's be frank, it's different. But I think we need to have a conversation, and it has to be led with the national government to the country. And it is, each of us are doing our own things. Each province is doing their own things. And trust me, the word change, when people talk about change, they just think it's negative. Like, there's no other aspect in our life. There's none that we would accept the system to stay the same as it was 50 years ago. People are fighting, Kathleen's point, to keep community hospitals. That doesn't mean we have to close them. Like we just put in, like we actually closed an obstetric unit. I remember calling the MLA representative of the area who had a video that said, as long as he was elected, babies will be born in my community. So I called him and I brought him in the Premier's office. Of course, you guys would have seen this. He's worried about what he did wrong. And I said, we have to catch up to the women of your community. He said, what? I said, 9 out of the 10 babies are born 30 minutes down the road at the regional hospital by someone who delivers babies for a living.
Right.
And there's a doctor for the baby. We're going to close the obstetric unit, but your community, by the stats we see, needs a dialysis unit.
Stephen, I think that the discussion is really at both levels, though, right? Like the points you were making about interprovincial trade and being able to practice anywhere in the country, that is definitely a national conversation, and the feds can force that. I don't think, though, that the federal government has the expertise and the depth of experience to be able to really conduct a national conversation. And I do think that people in different provinces feel very differently about it. I know that Ontario feels very different about it than Quebec. And, you certainly see that in the way that they operate the systems, because Quebec is actually allowed to innovate. And I do, if I think maybe this conversation needs to be had at a provincial level where provinces have a little bit more breathing room to maybe do difficult things and innovate and show other provinces what's possible. And we can, just like we do with education system across the country. We all have great education systems, but we all do it very differently.
Yeah, but Christy, I just would be really careful about using the word innovate and suggesting that Quebec innovates and Ontario doesn't. I mean, what you're saying is Quebec's moved farther along the continuum of privatization. Ontario has amazing medical innovation and research, So I think we have to be careful about the terms that we're using, because people get very, very worked up. People respond.
Well, but Kathleen, when I say innovate, I don't mean just private care, though. When I know that that's. And it's an interesting word because that's what you heard, but that's not what I was saying, right? So fair enough, right? It's maybe the wrong word to use if people think that just means private care, because innovation is a massive thing.
I was listening to something this week, and the physician was on, and they were talking about pilot projects. He said they thinks Canada leads the world in pilot projects in healthcare. But here's one of the things that happens: some of those pilots work, and some of those pilots have become programs. I don't think we've done a great job of sharing our provincial successes with one another, and I think the federal government can play a role in that. You know, one of the frustrations that I had always, every time it always ended up just give us more money. When you know, some of our conversations, and we would get together as premiers and health ministers should be talking about, you know, how has, you know, the pilot adolescent mental health program you started, how had that work? How did it work for you? What did it look like? And the system itself is very much opposed to, when I say the system, I'll speak about Nova Scotia, the bureaucracy is opposed to innovation in it in many ways because they're afraid of it. So how do you create a system that says, you know, the innovation that's happening in Ontario, that Nova Scotia sees it, shares it, and then I might need to adapt it a bit. No, quite frankly, no different than we do economically. And economic ideas that we see in other places, we adapt it to the model, the community that we live in. But how do we share those things? I think we need to create a portal of some sort where there's a national conversation. Well, what does our healthcare look like, and what are we doing really well? And what are the new things that we are doing? And you know, quite honestly, Kathleen, and I don't know this, but there may be something happening in Ontario that's completely innovative, how we deliver healthcare, which actually might make the government of Nova Scotia's conversation with its citizens a lot easier, because I'm not going into saying, I'm getting rid of your facility. I'm going to turn it into an urgent care center. And here's what.
And we've seen this work somewhere else. I mean, I think this, you know, it's interesting at this moment with the discussion about dental care that's happening with, Jagmeet pushing the federal government on dental care. I mean, every one of our provinces has a different approach to dental care, you know, and it's not that there is no dental care. It's woefully inadequate, I will say, in Ontario, but it actually might be, David, that, you know, an issue like this could push a more of a national conversation, because we're actually going to have to talk about how's that going to happen. It could have happened with pharmacare. That's, you know, that it hasn't, but it could be that an issue like this actually opens up a national discussion about what we can do, what we can't do, how we learn from each other, to Stephen's point.
You know, I did a survey recently, and I asked people how they felt about a bunch of different policy ideas. And one of the things I presented to them was expanding Canada's Medicare system to include drugs, dental, and long-term care. And, you know, I tested like 35 different policy ideas, and that was by far the most popular one in the
dental
group. No, in expansion of Medicare to include all those things.
All of them. Okay.
Right.
And what was the price tag on those, David? Just kind of curious as national programs.
Well, I didn't put a price tag on it for people. Just as a concept, though, they would like Medicare to be broader and to cover more things.
Right.
Not narrower, covering fewer things.
But
which
David,
speaks to the difficulty of a national conversation, right?
People want the healthcare system to do everything. And that's the cultural, I think that's one of the existential cultural issues that we're dealing with. And part of that is because they don't have the information, I think, about what the sacrifices are, what they're giving up to have, you know, what the costs are. People have very little information about how healthcare is actually delivered and what it costs.
Bingo.
And quite frankly, they're not happy with the current, what we do offer right now. I mean, there wouldn't be this much anxiety across the country if people were satisfied with the system that we currently have. So before we start adding layers of what else we're going to cover, we might want to figure out, how do we cover what we're covering?
Yeah, David. So thanks for that. Getting people all excited. Those
exactly.
3,000 people you contacted are now,
now
advocates. Yes. Yeah, good for
so
you.
Let's narrow in on the federal role for a few minutes here. And, a lot of decisions that might have to be made are very thorny political challenges for provincial governments. In my home province of Saskatchewan, Roy Romano closed rural hospitals in the face of a deficit crisis, a fiscal crisis in the early 1990s, and his political party has not recovered from that decision. So there's just some things, and you talked earlier, Stephen, about the difficulty of rationalizing healthcare in rural areas, for example. Some of these things are incredibly thorny. So let me present two options to you. And Christy, you tell me which one of these two you would have preferred when you were Premier. That the federal government bellies up to the bar with significantly more money, but also starts telling you what to do. Or the federal government transfers the tax points to you to fund the healthcare system and walks away from it entirely.
The latter. Absolutely. I think that, the federal government does not, healthcare is a provincial responsibility, just like education, just like a whole load of other stuff in the BNA Act. And they have, they got into healthcare by saying, we're going to pay for half. We're going to create this national program that's going to cost you, your provincial taxpayers, tons of money. But it's going to do a lot of really good things, and we'll pay for half of it. And they've really reneged on that obligation. And provinces, provinces are kind of stuck holding the bill for it. And you do see that different provinces do it differently. And Stephen is quite right. We don't work hard enough to learn from each other. And it would be great to have permanent fora where, and they kind of exist now, but it would be great to really be able to do that better across the country. But, you can't, the reason we have provinces in Canada is because we recognize that each province has its unique culture and its unique sensibilities. And so we are allowed to operate differently in areas like education, which are just as vital as healthcare, because we recognize that one size does not fit all in this federation. So let provinces run the healthcare system. Let them figure out, the Canada Health Act isn't a terrible thing, but we do, but that's a pretty loosely binding stricture that we've got. Leave it at that. Let the provinces run their healthcare system, make their own decisions about it, and be able to learn from each other, because we can see the innovations, the changes, the things that are working in different petri dishes across the country.
Either of you, what do you think about my question?
I agree with you, Christy. I think that would be very helpful. My only caveat would be is that the conversation is not going to end. So the feds could walk away, David, but as soon as the going gets tough, there's going to be a re-engagement, So you get these tax points and this, there's an escalator and whatever. But there will still be a re-engagement by the provinces if there's a need. So I don't love the idea of the federal government not having a role. I don't love the idea of there not being an engagement on a national level. And I think that like education, the provinces have the expertise, but I think there are some real problems in our education system because there isn't a national strategy. I think that training and adult education slips through the cracks all the time because there isn't a real engagement at the national level. So I think that I would want to see the federal government stay engaged, and I think it would almost be inevitable that they would.
Yeah, I think that latter part is true. They will not walk away from it.
Right.
But I don't think they should. There's nothing more sacred to a Canadian than our healthcare system.
Yeah.
And you want to fracture the country? Have the federal government walk away from the delivery of healthcare. What are there challenges? Sure. But I was one who, I didn't care if they told me where to spend the money, because they weren't asking me to spend it on things that I thought were ridiculous. Now, if they had an idea of putting in that, I just send us the money and we'll help. We'll deliver your outcomes that you're looking for. But I don't think we should, if we fracture our system up to our provinces and move away from a national role in this, I think it would be the wrong direction for the country to be heading. And let's face it, we also know parts of our economy turn pretty quickly. Look at what happened in Alberta with the resource. No one would have predicted oil prices dropping to the floor like they did, and the revenue for that province, tax points would have changed. without the federal government in play. All of that stuff is, I think, to me, I don't think it would work, and nor do I think it would be helpful for Canada. The one thing that Canadians will tell you, I think, that unites us is they want our healthcare system.
Yeah.
They might not like the current delivery of it, but how are we going to do that? And the federal government has to be part of that conversation. And
it's to your point, Stephen, it is definitional of who we are as Canadians, right? I think that is how people see themselves as Canadians, as having that the healthcare systems are close to the heart of that. And Christy, do you remember, I guess it was in 2015, we were sitting at the table with Trudeau and we were talking about mental health funding. And one of the ways we thought, because we were reaching, the end of the conversation about a general transfer payment. But there seemed to be some willingness to put some money on the table for mental health. And I think that there was a consensus. Well, there was a consensus around the table that mental health was a challenge and that we needed increased funding for it. And so that model of there being an opportunity for the provinces to find a way to come to some consensus, feed that into the federal government, and then the strings attached are not as onerous because you've actually created the opportunity, you've created the ties yourself, right?
Yeah, it's true. What I remember about that conversation was it was a way for us to we were trying to figure out, at least in my mind, how to get the feds to put in more money, right? It wasn't really, we would come up with any pretext available to try and get them to actually live up to their obligation of funding 50%.
When there's just the 14 of
mental
you.
health is a good example though, because in British Columbia, as you know, as everybody knows, the downtown east side is a mental health. It's a national catastrophe,
disaster,
what's happening down there. But that is not the same mental health issue that they have, for example, in Saskatchewan, where Indigenous people, there's a whole different texture to it in every province across the country. And I don't think it would really lend itself to a national, a singular national strategy in terms of implementation.
When there's just the 14 of you in the room, what is the federal government's argument to you about why they don't give you more money? I mean, the amount of money sloshing out of Ottawa in the last couple of years has just been astonishing. How can they must have a reason why they don't want to give it to the provinces?
Well, I don't think there wasn't really a reason. I don't remember a reason articulated.
But in fairness,
they didn't feel like it.
Under Stephen Harper and under Justin Trudeau, healthcare payments have gone up. They didn't go up as much as we wanted them to. That's the argument. There was a 6% rider, there was a 3% rider. So they have gone up.
Yeah.
And nowhere near 50%, Stephen. Yeah. Nowhere near 50%. And that was the argument we were making in 2015.
Right. So that's where I was going. That was the argument. But to say they haven't gone up, that's not true. Our argument is that they didn't go up to where we wanted them to.
But the inflation in healthcare, inflation's a hot topic right now, Stephen. But inflation in healthcare, in my understanding, has always been more than 6%, always been more than 3%.
Oh, yeah.
Always been more than 3%.
If I remember the discussion correctly, we were looking for 50-cent dollars. They were arguing they were doing 36-cent dollars, is what they always did. I said, okay, well, I've got 22-cent dollars right now. Can you meet me up to 36? I'll be happy.
Yeah.
And at that point, put a 6% rider on it, I think is what we were looking for, an escalator 6% through the life of this agreement, I think is how, if I remember correctly. But that's where we end up in these conversations. That's why, to Kathleen's earlier point about the issue around mental health, I think Sandy Silver was going to lead the conversation, him and maybe Brian Pallister, to have a forum, and then COVID broke out, a national forum. But I think it's a great example where if the federal government says, we want money spent on mental health, great, you send us the money. That's when it comes into the provinces, and we will do it differently because our systems are different.
Yeah,
they're not going to
because our societies are different.
Right, they're not going to come in and say, this is exactly how you have to spend this money. They're going to say, we want this money spent on mental health.
Yeah.
In our place, in our province, it's probably different than yours, and in Kathleen, it'll be different. So I think this whole idea of people worrying about the federal government telling you how to spend your money, To me, that was the least of our problems.
But Stephen, remember, David's question was, if the feds could give you all the money and you could spend all the money, or the feds would give you, the thing is, if the feds would give us all the money that they owe, if the feds would give provinces all the money that they actually are supposed to give the provinces, our healthcare systems would have so much money right now, right? We wouldn't be falling apart at the seams. That was the question that I heard from you, David. But maybe, I guess the other thing I would say is we forget that under Stephen Harper, he made a colossal mistake, I think, in healthcare when he went to Alberta and he said he gave them $1 billion gift for healthcare because he took out the age adjustment in it. Do you remember that? And for British Columbia and you folks out east, right, where we've got a much older population than in other provinces. When you take the age factor, right, older people are more expensive for healthcare. Younger people are cheaper. And Stephen Harper disentangled that and just treated every young person's dollar the same as every older person's dollar. And that, I think, was again, another. When you look at the total healthcare money that we all get, that decision that he made, which I don't think the current federal government has changed, has had a really distorting effect for every province, especially places that have lots of old people like Stephen's province and mine. Mm-hmm. Not that you're old, Stephen. You're not in that category. David, if David moves to
exactly.
Nova Scotia, then the whole
And I would be so thrilled to move to Nova Scotia.
We were sending a lot of our young people to Alberta to build the economy, and then when they were ready to retire, they'd come home so we could look after them.
Yeah.
So, I'm interested in private delivery because I'm a Medicare advocate. And it makes me nervous. And I know that there's a ton of it in the system, but it always feels like a slippery slope to me. So I want to ask you, should we be fussy about public versus private delivery? And did you, when you were premier, see any evidence that private delivery actually would improve the system?
Are you talking to me, David?
Any of you. I'm talking to any of you.
Okay, I'll go first, and then Kathleen and Stephen can contradict me. So
maybe I'll agree with you.
Maybe I will. I shouldn't prejudge. I apologize. So yeah, it was a real safety valve for the public system for sure. Nurses and doctors would move back and forth across the system. It meant that a lot of people could get timely care in the private system, and then suddenly the lineups were shorter in the public system. So it was a really, really important safety valve that was there. And it was medically necessary surgeries, right? So, and which of course includes hip and knee surgeries. And as Stephen said, if you have a bad hip and you can't go into work for 2 years, you're probably never going back again. But so it's limited, but it didn't threaten the public system at all. In British Columbia. In fact, I would argue we have had one of the best functioning healthcare systems in the country, partly because of that access to private care for people. And it also meant that, for doctors, for example, instead of being able to get on the slate, for surgery 3 times a week, they could, which you can in the public system, they could move it over into the private system and do another 10 surgeries or whatever it was, right? So they were able to practice their trade more consistently, which I would argue also made them better professionals. So, we have the guardrails in place to stop this becoming a slippery slope like the United States. But again, I mean, it's the crazy thing is in Canada, the only system we compare ourselves to is the American system, which is the worst system in the Western world. Mm-hmm. Let's compare ourselves to Denmark and Sweden and Finland and Germany and countries around the world that have a parallel system where people cross back and forth as patients and as professionals within the system, and it works extremely well. Poor people are not disenfranchised, and you do end up with, they have lots of other problems too, but it hasn't been the private system working in parallel to the public system that's causing those problems.
But Christy, you were talking, when you say the private system in BC, you're talking about a publicly funded, privately delivered, right?
No, I'm talking about both.
Okay, but that's what David was talking about, I think.
Yeah.
Yeah. So some of it is publicly funded, like you go get your knee done.
Yeah.
Right.
The Workers' Compensation Board will pay for that at a private clinic. But as an individual, you could also pay for that personally.
Okay. So, David, as I understood your question, I mean, we do cataract surgeries in that way in Ontario, right? Their lab services are publicly funded, privately delivered. If you think about it, sole practitioner docs are actually a private delivery system, publicly funded. So I actually, philosophically, I don't have any problem with private delivery, public funding. I have way more problem with privately funded, because I think that's where the divide happens. That's where people who have are going to get more than people who don't have. And it's like a charter school system where you cream off the people who can, who are kind of in one echelon. So I am, if you're asking me, what do I think about private delivery, public funding? I think we already do that. And I think that's not a problem. We have to watch it. We have to be careful. But private pay, I think, is more problematic.
Yeah, like the Canada Health Act has 5 principles to it. And I think I could argue that when we talk one of them is accessibility. But when we talk about this as a value system for Canada, we're really talking about 2 of them. Single payer, universal. Mm-hmm. Right?
Yeah.
And after that, Canadians probably are prepared, and I don't think Canadians would tolerate any fudging on those 2 issues. Right. But once you get past that, it gets a little murkier, right?
Well, and then what's universal? I mean, that's the challenge really that we have now in the system is that, and Kathleen was talking about, so was Stephen, that the services that we provide are so vast now. This isn't what Tommy Douglas and Lester Pearson talked about back in the day when Kathleen's dad was practicing medicine. This is like, it's not a GP who, and a few surgeries. It's everything under the sun. So what the question really is, what is Canada, what do provinces in Canada provide for citizens that is universal? Is it everything? Because that's actually, really, you want to talk about private care? That's what this debate is about. Where does universal end?
Well, I think universal, but the way we've operated within the system, Christy, is that whatever we do choose to offer is universal, right? But the discussion about what gets added, it's never, although I think it's going to be with dental care, if we add dental care, who's going to have access? Is it universal or is it a needs-based, right? I think it's going to be a different conversation than we would have had about, okay, now we've got technology that improves cataract surgery. Well, everybody can have access to that. I think the dental care and pharmacare are going to be different from that perspective.
But if Medicare was needs-based, it wouldn't have the same value as resonance with Canadians. It's because it's universal.
Hey, right. If Medicare was needs-based, you wouldn't have to wait 24 months to get a knee operation. There's actually the opposite argument as well, right? Which is we don't have a needs-based. We don't have an urgent concerns are not getting dealt with. People with serious heart disease are waiting months and months and months to get their operation done because the system is not needs-based. It is not responsive. It's become so broad that we don't really do anything as well as people expect us to do, and as well as sort of the promise of healthcare would suggest we should be doing it. The promise of Medicare should be doing it.
Can I just ask one question, David? So, Christy, are you saying that, even now, but certainly pre-COVID, the system was so broken that if someone walked into an emergency room with a serious heart condition, you're saying people were not getting the service that they needed? You see, that has not been my experience in Ontario. That is actually one of the things that has been done well. But as soon as it wasn't an emergency that was leading to death, then we went into the rabbit hole of waiting. That's right. My experience.
Yes. And the problem is with heart disease is that you don't know how serious it is until you open up the body, right? And doctors, specialists have said for a long time, I've heard this throughout my political career, that they are scared that their patients are just going to start dying on them because they can't get them into surgery quickly enough. I mean, that happens all across the healthcare system with all kinds of different issues. Brain cancer, you can't get the MRI that you need or the CAT scan that you need. And that, that's actually the problem we have with healthcare is, I would argue, it's not being universally well delivered for people because we've just gotten really bad at it because it's so expensive and what's covered is so broad.
To take this back to where we started, you look at some of the emergent. This is really a primary care issue in many ways, though, on the front end of this thing. That's why this thing is really hitting the front page of the papers. People don't have access to primary care, and they're ending up in emergency rooms and waiting 18 hours, and however, and some being sent home, come back the next day. There's all kinds. I mean, that it may be a bit, that was something that was happening in Nova Scotia pre-COVID. You were getting, and it goes back to the primary care delivery model. I would argue it's now getting some national attention because it's happening in other places. So what does that delivery model? The discussion has to be, what are the processes in front of us that allows us to deliver care to the patient? And ultimately, that's where we got to go back to, what is the best way to give care to our citizens, individual Nova Scotia Canadians? And I don't think anything should be off the table. I'm not in full disclosure. I'd be one of those Canadians that doesn't want where I can go write a check to get something done. But I don't think we should limit our debate in the country about what this looks like. I think every Canadian should have a conversation about what does it look like. In Nova Scotia, for example, long-term care is, the vast majority is privately run. They follow the parameters of what we have with the buildings. We put structures around them. The privately run facilities in Nova Scotia stood up really well to COVID. Where we had our largest outbreak was actually in the not-for-profit, which happened to be the largest long-term care east of Montreal facility. So there is a role, and I think, to me, to Kathleen's earlier point, which I said when we started, I go see my doctor. I don't pay him, but he gets paid by the government to come to see me and how long it takes. He's an entrepreneur. So all we're saying in other long-term care is the same way. The government writes a check to a private operator, and there is a bit of a needs based on that. After a while, you get a certain amount where we pay. Kathleen talked about cataracts. Listen, there was early on in my mandate, I was invited to this private OR suites where they were doing cataracts for outside of the hospital. I said, I can't believe we're doing any cataract surgeries in hospitals. Why don't we just figure out a cost of what it's going to do and send everybody to that OR and we'll pay it. They don't pay when they go. We'll pay it. We'll pay the bill, but we don't own the facility. So figure out what that looks like. I think those kind of conversations, and even though it may be happening in some parts of the country, in other parts it gets used to ratchet up the debate about, well, that's private healthcare. Well, it's not private healthcare. It's I don't pay. The government's still paying. How it gets delivered, and I go back to this point. We have a chance to shape the delivery model to meet the needs of Canadians today and for the next 50 years. That means some stuff's going to have to change. And we have to be open to what's really working everywhere, including in other provinces and in other countries, about the best way to deliver it.
And I think it's really urgent that we do that, because I think I know I'm the pessimist in this group for sure. I think our healthcare system is in real peril right now, real peril. And I think it is, 50 years, we may not have a Medicare system. I think in 15 years, we could be looking at something that's radically different. So we can think about the decisions we want to make to shape that, to adapt to that future, or we can just let it happen to us, which will be a bad outcome.
But change is happening every day. And I used to say this: we either shape it or it shapes us. I prefer to shape it. And do we always get it right? No. Do every decision governments make? Mark, no. But I'd rather be attempting to how do we shape? Because
David, to your point, when you were talking to Christy about taxing people, we're taxed. There's no more room to tax people in Nova Scotia. I don't know about the rest of the country. There's no more room. But
everybody in British Columbia wants way more taxes.
But in order for me to, I have to grow the economy. But that means I need some of those tax dollars that I currently get. I can't spend them all in healthcare. So when I deliver healthcare, education, and community services in Nova Scotia, there's not much left.
Well, presumably, though, the feds would say, Stephen, well, then you want me to borrow it because theoretically I have to tax for it too if I'm going to give it to you.
Yeah.
Right.
Well, that's a whole different question. They never asked me how they should spend their money. No federal government of either stripe actually called me up and said, how should they spend their money on what programs? We invested in the private sector. We invested in immigration. Our province got younger for the first time in my lifetime in 2019. So in that whole time we were aging. So we need to be able to do those stuff, to Christy's earlier point, to help us pay for the healthcare system that we want to try to reshape. One of the challenges, and I don't know whether you guys have experienced this, every time you almost introduce something to the system, which is going to ambulance services, for example, which Nova Scotia started back in the 90s. Well, we introduced it at the same time we cut beds. So there was a really tough transition.
Mm-hmm.
Instead of introducing it, getting it up and running and making sure, and then start reducing the acute care bed capacity in hospitals, we did them both almost simultaneously, which is a tough way to change the system. And I don't have the answer for it, but it is almost a case of there needs to be an influx with the idea that we're going to change you to what's new before we get rid of the old, and we're going to give a 5-year window of doing them both at the same time. But I don't know how to do that. But
David, one of the things that I think, to the point about the juncture that we're at right now, one of the greatest dangers, I think, is that people, because of the COVID impact, because of the front page stories right now, people start to lose confidence in the system. And that is really, really dangerous, because I think then that opens the door for quick solutions that actually don't get at the root of the problem. And so my hope is that very, very quickly, governments at both the provincial and the federal level understand that there need to be some injections of cash, but also solutions right now to deal with some of those very emergent problems. And then that other conversation that we're talking about can happen. But, the terms have to be defined. Like even in this conversation with 4 people who, know something about this issue, we have to be clear whether when we talk about private versus public, are we talking about private delivery? Are we talking about public delivery? Are we talking about private payment or public payment? Those terms have to be defined so that we actually know what we're talking about, because depending on how they're defined, we find ourselves on different sides of the issue, right?
Right. Christy, do you have any last thoughts? I've presumed on all of your time too much, but got a shout out to the people that are current custodians of our healthcare system, what they should be thinking about or doing?
I would say we have to have this conversation soon, really fast. We have to, the train is just barreling down the tracks. We're recession, high interest rates. It's going to be very difficult for governments to pay back collectively, start paying down the debts that we all have. Governments, the debt is going to become more expensive for governments than the growth in healthcare by a long shot very quickly. So change is going to be forced upon us, or we can decide what that change is going to look like. And it is going to be really hard for politicians to make those changes. And Kathleen's quite right. You want to get to the root of the problem. I don't think we're going to have the luxury, though, of time that will allow us to getting to the root of the problem is going to take some time.
Yeah.
While we do that, we are also going to have some faster solutions that are going to help us find ways around this. The staff shortage is something we really need to be thinking hard about, because if you can't staff hospitals, you can't staff urgent care clinics, and you don't have GPs, you don't have a healthcare system. You don't have people, you have no healthcare. And that's the first most urgent problem I think that we need to solve. And I haven't seen really any solution nationally or in provinces across the country that's very realistic about that yet.
Well, I would say to that, I don't know if you were going to ask us both this question, or all three of us this question, David, but I would say two things. I would say to the decision makers, the people on the front line need help right now. Like, they can't, to Christy's point, they can't wait for the longer conversation. They need help right now. That means money to get more staff into those emergency rooms and into those hospitals and into those care facilities. Like, that's just the first thing that needs to be done. And if I were sitting in the Premier's chair in Ontario, I would be saying, okay, where does the money have to go? How do we find the people? How do we get them in there? That's what I'd be saying. And then the second thing is that, then we need to have that broader conversation, and then the feds need to be part of it, and we need to dig into it. But right now, get those people some respite, get them some support, because they are burning out and they are what's holding the system together.
Terrific. Stephen?
So I would agree with both of my former colleagues, but I do think the most urgent issue right now is HR. We need more people, and we need colleges. We need all of them to step back and recognize they need to loosen up some of the restrictions about people coming into our respective country and provinces. The federal government can play a role in that. But what I would say to all of them, it's a privilege to be a premier. It's a privilege to lead a government. You are at an opportunity, they have an opportunity, in my view, to reshape the delivery of healthcare for the next 50 years. Don't waste it. And it needs the federal government to be part of it. That doesn't mean that we're going to tear up our system, but it does mean it has to reflect our realities of today and the needs of Canadians today. And I would strongly encourage them, don't look at this as a bad thing. That's a gift. Who else? Listen, wouldn't each of you had wondered the opportunity to run into crunch to reshape the delivery of something in your respective provinces? This COVID, this has laid open the system. While there were problems in before COVID, it's kind of laid it open. Now they have a chance to reshape it. That's a gift for them. Take it and run with it.
Awesome. I'm so thrilled that I know the three of you epitomize public service to me. And this conversation that we've had today doesn't exist anywhere in the Canadian political space. And it's really important that it does. And I hope we've kickstarted something with this conversation this afternoon. Thanks for doing it. And yeah.
It was great to see everybody, Kathleen and Stephen.
Great to see you both.
You guys.
Great to see you all.
Yeah. I'll have to thank our presenting sponsor, TELUS, and our sponsors, CN, Rail, and Google, and thank all of our listeners, and of course, Stephen McNeil, Kathleen Wynne, Christy Clark. You are the best.